Hey everybody, welcome back to Psych Synced. My name is Prescott. I'm here at Succinct Psychology or Psych Synced. I just said that, but anyways, today we're going to be starting Chapter 15, Psychological Disorders from the OpenStax Online Psychology 2E textbook. This is a long chapter, so we might be going through this for a bit, but I'll try and get it done, quick and concise for you guys. So let's get started. So, definition of a psychological disorder. Now, psychopathology is the study of psychological disorders, including their symptoms, etiology or causes, and treatment. Now, a psychological disorder is a condition characterized by abnormal thoughts, feelings, and behaviors. So, behaviors, thoughts, and inner experiences that are atypical, dysfunctional, or dangerous are signs of psychological disorders. However, there is no single definition of psychological abnormality or normality. So just because something is atypical does not mean it is disordered. Red hair is considered unusual, but it's not abnormal. So examples, you have Isla Fisher, Prince Harry, Marcia Cross, they're all natural redheads. It's atypical, but it's not abnormal. It's not like, oh my God, they have red hair. What's wrong with them? So definition of psychological disorder continued. We have cultural expectations. So violating cultural expectations is not enough by itself to identify as a psychological disorder. Social norms vary between cultures, so what is considered appropriate in one culture may be viewed differently in another. So hallucinations is a violation of cultural expectations in Western societies. People who report hallucinations are likely to be labeled with a psychological disorder. However, in some other cultures, certain types of hallucinations are highly valued. So a harmful dysfunction, Wakefield, 1992, proposed a more influential concept in which he defined psychological disorders as a harmful dysfunction. Now, dysfunction occurs when an internal mechanism, example, cognition, perception, and learning, breaks down and cannot perform its normal function. For dysfunction to be classified or classed as a disorder, it must also be harmful or leads to negative consequences for the individual or for others as judged by the standards of the individual's culture. So continuing on, we have the American Psychological Association, or APA definition. A psychological disorder is a condition that consists of the following: significant disturbances in thoughts, feelings, and behaviors, outside of cultural norms, of course, and the disturbances reflect some kind of biological, psychological, or developmental dysfunction. The disturbances lead to significant distress or disability in one's life. Example, difficulty performing appropriate and expected roles. Well, despite the many existing definitions, there is no universal agreement on where the boundary between disordered and not disordered is. So, the Diagnostic and Statistical Manual of Mental Disorders, or the DSM. Diagnosis is appropriately identifying and labeling a set of defined symptoms, requires classification systems that organize psychological disorders systematically. The Diagnostic and Statistical Manual of Mental Disorders is published by the American Psychiatric Association and was first published in 1952 and has since undergone numerous revisions. The first two editions listed homosexuality as a disorder, but was removed in 1973. Now, DSM-5 is the classification system used by most mental health professionals and categorizes and describes each disorder. So, diagnostic features, an overview of the disorder, diagnostic criteria, which are specific symptoms required for diagnosis, prevalence, so percent of population thought to be afflicted, and risk factors, and provides information about comorbidity, or the co-occurrence of two disorders. So, prevalence rates in the DSM-4. The graph shows the breakdown of psychological disorders comparing the percentage prevalence among adult males and adult females in the United States. Now, the DSM-4 has since been supplanted by the DSM-5, and most categories remain the same. However, alcohol abuse now falls under a broader alcohol use disorder category. So you can look there for yourself. This is DSM-5, alcohol abuse. Blue is total, red is females, green is males, and then the lifetime prevalence rates. So if you guys are interested, I'm not going to go through each one, but if you want to pause the video and take a look for yourself, feel free to do so. So, comorbidity in the DSM. Obsessive compulsive disorder and major depressive disorder frequently occur in the same person. So you can see they have a comorbidity of 41%. So that one person, 41% chance, or 41% of people. I worded that wrong. But anyways, you get what I mean. They frequently occur in the same person, 41% of the time. Now, the International Classification of Diseases, the ICD, is published by the World Health Organization, or the WHO, and classification and criteria for specific disorders are similar to the DSM-5, but some differences exist. is used to examine general health populations and monitor prevalence of diseases/health problems internationally. And worldwide, the ICD is more frequently used for clinical diagnosis, whereas the DSM is more valued for research. Now, the DSM includes more explicit disorder criteria as well as extensive explanatory text. And the DSM is the classification system used among U.S. mental health professionals. Not professionals. So, here's some supernatural perspectives. For centuries, psychological disorders were viewed from a supernatural perspective. So that is, a psychological disorder is attributed to a force beyond scientific understandings. So, practitioners of black magic, sorcery, possessed by spirits, and witchcraft. Now, treatments included torture, beatings, and exorcisms to treat somebody with a psychological disorder. And the extraction of the Stone of Madness, a 15th century painting by Hieronymus Bosch, a practitioner is using a tool to extract an object, the supposed Stone of Madness, from the head of an afflicted person. Dancing mania, epidemic in Western Europe, 11th through the 17th centuries, in which groups of people would suddenly begin to dance with wild abandon. Some would dance for days or weeks, screaming at terrible visions. Although the cause is unknown, the behavior was attributed by many to supernatural forces. So, biological perspectives is a view that psychological disorders is linked to biological phenomena, so genetic factors, chemical imbalances, and brain abnormalities. It is supported by evidence that most psychological disorders have a genetic component. A person's risk of developing schizophrenia increases if a relative has schizophrenia. The closer the genetic relationship, the higher the risk. So here you can see here, depending on how the percent of genes shared, the higher the risk goes for developing schizophrenia. And here you can see the relationship. So if they're identical twins, they have a very high risk of developing schizophrenia. So diathesis stress model. So the psychosocial perspective emphasizes the importance of learning, stress, faulty, and self-defeating thinking patterns, and environmental factors. Now, it views the cause of psychological disorders as a combination of biological and psychosocial factors. The diathesis stress model integrates biological and psychosocial factors to predict the likelihood of a disorder. Now, diathesis plus stress equals development of a disorder. So, diathesis is vulnerability to the stressor. So the two combined lead to the development of a disorder. People with an underlying predisposition for disorder, like I just said, diathesis, are more likely than others to develop a disorder when faced with adverse environmental or psychological events. A diathesis can be a biological or psychological vulnerability. Now, anxiety disorders, so fear versus anxiety. Fear is an instantaneous reaction to an imminent threat. So if you see a lion running at you, you're going to have fear. And anxiety is apprehension, avoidance, and cautiousness regarding a potential threat, danger, or other negative content. So anxiety would be like when you have anxiety for your final coming up in a week. That's anxiety, not fear. Now, it motivates us to take action and avoid certain things, and level and duration of anxiety usually matches the magnitude of the potential threat. However, some people experience anxiety that is excessive, persistent, and out of proportion with the actual threat. So anxiety disorders, that's where these come in, are characterized by excessive and persistent fear and anxiety and by related disturbances in behavior. Now the prevalence, it affects approximately 25 to 30% of the U.S. population during their lifetime, more common in women than men, and most frequently occurring class of mental disorders. Next, we have a specific phobia, which involves excessive, distressing, and persistent fear or anxiety about a specific object or situation. People may realize their fear and anxiety is irrational, but may still go to great lengths to avoid the stimulus. So prevalence affects 12.5% of the U.S. population at some point in their lifetime, and some common specific phobias include acrophobia, which is heights, aerophobia, which is flying, arachnophobia, which is spiders, and claustrophobia, or enclosed spaces. Now, agoraphobia is listed as a separate anxiety disorder and characterized by intense fear, anxiety, and avoidance of situations in which it might be difficult to escape or receive help if one experiences a panic attack. These situations include public transportation, crowds, or being outside the home alone. So this common misconception that agoraphobia is the fear of the outside. No, it's a fear of having a panic attack and no one's around. There's no way for them to get help. That's why, like being outside their home in a big open space by themselves, there's no one around to help them. It's not they're scared of the sky, right? So, acquisition of phobias through learning. So Rachman, in 1977, 3 major learning pathways. Classical conditioning, which we talked way back when about. So here we go, classical conditioning. Not in such a positive light, though. Child is bitten by dog, unconditioned stimulus. Dogs become associated with biting, so that's a conditioned stimulus. So the child experiences fear around dogs, continued conditioned response. Conditioned fears develop more readily to fear relevant stimuli, so images of snakes and spiders, than to fear irrelevant stimuli, so images of flowers. Vicarious learning, child observes cousin react with fear around spiders. Child later expresses these same fears even though spiders have never presented any danger to him. And then there's verbal transmission of information. So a child is continuously told that snakes are dangerous. The child starts to fear snakes. Why are certain types of phobias more common than others? One theory argues that because our ancestors associated certain stimuli with danger, for example, snakes, spiders, and heights, we are evolutionary predisposed to associate those stimuli with fear. So, next we have social anxiety disorder, which is characterized by extreme and persistent fear or anxiety and avoidance of social situations in which the person could potentially be evaluated negatively by others, leading to serious impairments in life. It is associated with lower educational attainment, lower earning, poor work performance, and unemployment. Some safety behaviors, mental or behavioral acts that reduce anxiety in social situations by reducing the chance of negative social outcomes. So a safety behavior, for example, is avoiding eye contact or rehearsing sentences before speaking. Prevalence is experienced by about 12% of Americans during their lifetime, and the comorbidity of it is a high rate of comorbidity with alcohol use disorder. Individuals may self-medicate to reduce anxiety in social situations. Some risk factors include fears of social situations, possibly developed through conditioning. 92% of a sample of adults with social anxiety disorder reported a history of severe teasing in childhood. And then behavioral inhibition is a consistent tendency to show fear and restraint when presented with unfamiliar people or situations. Next, we have panic disorder. So panic disorder is the recurrent and unexpected panic attacks along with at least 1 month persistent concern about additional panic attacks and worry over the consequences of the attacks or self-defeating changes in behavior related to the attacks. So the comorbidity of anxiety disorders, there's a high comorbidity between anxiety disorders or major depressive disorder. Panic attack is a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. It can be expected in response to an external trigger or unexpected. Panic attacks alone are not a disorder. Some of the physical manifestations of a panic attack are shown. People may also experience sweating, trembling, feelings of faintness, or a fear of losing control, among other symptoms. So here's some symptoms: feeling dizzy, unsteady, and lightheaded, shortness of breath, chest pain, palpitations, and or accelerated heart rate, nausea, or abdominal distress. Continuing on, so here's some causes of genetics. 1 second, guys, my mouse, there we go, froze up on. Genetics, there's 43% hereditability, so remember, the closer your genes are to somebody, more likely you are to heredit one of these, or however you say that. All right, you have more hereditability, basically, is what I'm trying to say. Next, we have neurobiological theories. So locus coeruleus in the brainstem is possibly involved. Major source of norepinephrine, which is the neurotransmitter that triggers fight or flight response. Activation is associated with anxiety and fear and produces panic-like symptoms in non-human primates. Some conditioning theories. Panic attacks are classical conditioning responses to subtle bodily sensations resembling those normally occurring when one is anxious or frightened. Cognitive theories. Individuals with panic disorder are prone to interpret ordinary bodily sensations catastrophically, setting the state for panic attacks. In some patients, reducing catastrophic cognitions about sensations has proven to be as effective as medication in reducing panic attacks. And we're going to go through generalized anxiety disorder, and then I will wrap it up. I apologize, it's a longer video, but I just don't want to have so many videos with so many intros eating up y'all's time. So, generalized anxiety disorder, a relatively continuous state of excessive, uncontrollable, and pointless worry and apprehension. So, diagnosis criteria: the diffuse worrying and apprehension is not part of another disorder. Symptoms occur more days than not for at least 6 months. and symptoms are accompanied by any three of the following symptoms: restlessness, difficulty concentrating, being easily fatigued, muscle tension, irritability, and sleep difficulties. Prevalence affects about 5.7% of the U.S. population during their lifetime, and females are 2 times as likely as males to experience the disorder. Comorbidity is comorbid with mood disorders and other anxiety disorders. Next, we have cognitive theories, which worry represents a mental strategy to avoid more powerful negative emotions, perhaps stemming from earlier unpleasant or traumatic experiences. Worrying acts as a distraction from remembering painful childhood experiences, and longitudinal study found childhood maltreatment was strongly related to development of the disorder during adulthood. So see somebody who looks very worried in that picture there. Generalized anxiety disorder. But anyways, next we have OCD. This should be very interesting, but we are going to stop there for today. Hope you guys enjoyed the video, and hope to see you in the next part. Again, my name is Prescott. I'm here at PsychSync, the Sync Psychology, and I will see you in the next video. Thank you. Bye-bye.